Hi, everyone. My name is Nick. I am a rising M2 at the University of Illinois College of Medicine at the Chicago campus. Today, I will be presenting on chapters 19 and 20 of the IR Playbook. So, this is just a review of aortic aneurysms. Chapter 19 focused on thoracic and thoracoabdominal aortic aneurysms. I first want to start by discussing the pathophys and also some epidemiology of these aneurysms. So, a thoracic aortic aneurysm is classified as a dilation of over 50% in comparison to a normal diameter. So, as soon as the diameter gets to around 4 to 4.5, that's depending on the person, can already be considered aneurysmal. 13% of those with thoracic aortic aneurysms have degeneration of other levels of the aorta, showing that this is quite a systemic problem throughout the entire aorta and other arterial vasculature within the patient. Recently, there's been an increase in incidence that's likely due to increased screening. And there's also been an increase in rupture, and that's likely due to an aging population. The graph that I have on the right side of the screen is from a JTCS article. This is quite outdated, but the trend is still consistent regardless. It starts from 2003, so it's a decade of data, but the blue dotted line is reflecting aneurysm numbers, specifically TAAs, and it's been increasing throughout that past decade, and we can see a constant trend currently as well. An important distinguishing factor between the ascending and descending aorta is where the cells are derived from. So the ascending aorta has cells that are derived from neural crest cells. So this is from the neuroectoderm, and medial degeneration can occur here. So there's smooth muscle cell dropout and also elastic fiber degeneration. This is different from the descending aorta, and these cells are derived from the periaxial mesoderm. So these are smooth muscle cells, and degenerative disease is more likely to occur in this area. So risk factors could be atherosclerosis, tobacco use, history of aortic dissection. So I will talk about those in this slide. So I previously mentioned atherosclerotic disease, history of aortic dissection, also trauma, infection. These are predisposing risk factors for thoracic aortic aneurysms. Connective tissue disorders also have a strong link with TAAs, so Marfan. So if there's a mutation in the FBN1 gene, which codes for fibrillin, Turner syndrome, which can lead to cystic medial degeneration, also mutations in TGF beta. So this could lead to ECM and collagen overproduction. In addition to this, patients who have aortic vesiculitis, such as GCA Takayasu, they're more prone to developing TAAs. In addition to this, bicuspid aortic valve patients, and if a patient has a familial history of TAA syndrome. And this is a graph from the Healthline. This is just showing the two different locations where TAAs can arise from. So you can have an ascending aortic aneurysm, you can have descending aortic aneurysms. You can also have aneurysms in the arch of the aorta, and I'm going to go over that very soon. So this is the zonal anatomy of the aortic arch. There's 4 zones. The first zone is the proximal portion of the ascending aorta. It includes the right brachiocephalic artery. Zone 1 includes the left common carotid. Zone 2 includes the left subclavian. And then zone 3 is the proximal portion of the descending. And then zone 4 is the mid-descending portion. And then as the aorta continues downwards, that eventually turns into the abdominal aorta once it passes the diaphragm. So aneurysms can occur in any of these locations. It can occur in the ascending portion, it can occur in the arch, descending, and then if the sac extends throughout the thoracic and abdominal portions of the aorta, then it's considered a thoracoabdominal aneurysm. The Crawford classification is used to classify thoracoabdominal aortic aneurysms. There's five different types. I'm going to go over each one. The next slide has labeled images, which makes it even easier to tell. But this is a type 1 Crawford, so it includes the portion of the left subclavian. So this would be zone 2. This will be zone 2 and also including zone 3 and zone 4 and beyond. And this extends into the abdomen, but it does not pass the renals. The renals are around L1, L2. A type 2 Crawford also includes the left subclavian, but this extends past the renals and can even include the aortic bifurcation. A type 3 arises from the distal half of the descending aorta and it extends beyond the renals. Type 4 extends from the diaphragmatic hiatus to the aortic bifurcation. And then a type 5 extends from the distal descending thoracic aorta, but it does not extend past the renals. And then these are all the classifications listed once again. I'll go over them just so we have some repetition and we can get a better idea of these. So type 1, once again, left subclavian involvement does not pass the renals. Type 2, left subclavian involvement does pass the renal. So this is quite a large amount of space that this sac is taking up. Type 3 is the distal half of the descending. It extends past the renals. Type 4 is the diaphragmatic hiatus to the aortic bifurcation. And just for a review, the aorta crosses the diaphragm at T12. Celiac trunk is around T12 L1. SMA is around L1, and then renals L1, L2. And then type 5 is descending half of the descending. It does not extend past the renals. These are some clinical findings that you may expect. So typically, thoracic aortic aneurysms as well as abdominal aortic aneurysms, they're found incidentally. So patients usually present with no clinical symptoms. But if a patient does have symptoms, they usually present with nonspecific abdominal, back, and sometimes even flank pain. And this is a medical emergency. This requires immediate repair. Sometimes patients can present with limb ischemia, so the aneurysm can act as a nidus for thrombus formation. Due to irregular blood flow within the nidus, it's an area that's more prone to thrombus formation, so this could lead to distal embolization. And once again, I mentioned that this is quite a rare uh, finding, but it is still possible. Ruptured thoracic aortic aneurysms, patients usually present with severe chest pain, abdominal and or back pain. This is different from dissection. So if a patient has a dissection, they usually complain of a tearing chest pain that radiates to the back, and they also have severe hypertension. Another finding that may be present in a patient that has either a dissection or an aneurysm is blood pressures that are not equal in the upper extremities. And then I included this chart on the right side of the screen. This goes over dissections. I know this chapter is about aneurysms, but I think it's still important to mention. So there's three subtypes and then two main types. So there's type A and type B. So type A dissections, they always include the ascending portion of the aorta. And then type 1 specifically also includes the descending portion. And then type 2 does not include the descending portion at all. And then type A differs from type B medically in the sense that type A requires immediate surgical repair. Type B that only includes the descending portion, does not include the ascending portion. And depending on the severity of type B dissections, they could be treated medically just with beta blockers. But if it's a more urgent case, then it may require immediate surgical repair. These are some of the guidelines for treatment. So the right side of the screen, I took a screenshot straight from the IR playbook. I wanted to mention some of the more high yield points. So if a patient is symptomatic, you always want to treat them. If the aneurysm grows at approximately a rate of half to around 1 centimeter a year, that means that the aneurysm is growing quite rapidly, and that also requires um, immediate evaluation, also likely a repair. If a aneurysm grows to over 6 centimeters, then it's at a significant risk of rupture or dissection. If a patient is asymptomatic, then you usually want to treat them at around 5.5 centimeters. Systemic vascular disorders, so I previously mentioned GCA, Takayasu, those patients are also more prone to rupture and dissection, so they should be treated at around 4.5 centimeters. And then a typical normal aorta is around, or typical normal thoracic aorta is around 2.5 to 4 centimeters. But that, of course, is different based on the sex and also on the patient themselves. There are different open treatments that are used for thoracic and thoracoabdominal aortic aneurysms. So a Bentall David can be used, total arch replacement, thoracoabdominal repair. Um, I wanted to mainly focus on how VIR treats these conditions, but I wanted to just include the different surgical options that are available for these patients. Interventional therapy, so TVAR is what is used. So this is a thoracic endovascular aortic repair. I'm going to go into more details on the following slides, but I just wanted to include a quick schematic of what this treatment looks like. Um, this is a TAMBI, so this is one of Gore's devices. It stands for thoracoabdominal branch endoprosthesis. I'll play a really quick clip from Gore's YouTube page, and I'll speed it up. The main thing that I wanted to highlight is how complex this graft is. There's so many different branches, and it's important that it's as flush as possible with the arteries and all the branches so it can so it's able to prevent blood flowing back into the sac. If that happens, that's an endoleak, and I'll talk about endoleaks later on. But I think it's so fascinating that we can do all of this endovascularly. These are other important treatment considerations. So a CTA of the head, neck, chest, abdomen, pelvis with 3D reconstruction is important. It's a good way to understand the health of the arteries, both of the visceral arteries and as well as the aorta. If a CTA has been done several times, then you have a better idea of how the sac has been progressing over time. It's also imperative to evaluate the iliac and femoral arteries for access. This is quite a large graft, so the sheath size is around 8 French minimum, I believe. So it's important to have good access for these procedures. You also want to appropriately size the graft itself. So you want at least 2 centimeters of healthy tissue, both at the proximal and distal landing zones. I'm going to mention this later on, but this is really important for preventing endo leaks later on. And because of this, the device should be oversized around 10 to 20%, but it's important that it's not excessively oversized. This can lead to dissections, device enfolding, and type 1 endo leaks. And then this is another graft. This is from Cook. This is the Zenith T branch thoracoabdominal endovascular graft. These are some clinical trials that were done in this space. I didn't go too in depth because I just wanted to include as much as I can, but just cover the heavy hitting points. So in Valor 1 and 2, TVAR was compared retrospectively to cohort of open surgery. TVAR had significant reductions in 30-day perioperative mortality, only 2% for TVAR and 8% in open. And then major adverse events was 41% for TVAR, 84% for open. Then the TAMBI pivotal trial occurred for the TAMBI device. It resulted in 0% 30-day perioperative mortality, 99% technical success rate, and also a 94.2% one-year freedom from TVI. So this is target vessel instability, showing the patency of these grafts long-term. The ZFEN pivotal trial, this is for a triple A juxtarenal aneurysm device, if I believe correctly. So this isn't as applicable for thoracoabdominal aortic aneurysms, but it's still a complex aneurysm, and I'm going to talk about it a little bit later. 5-year data showed 91% freedom from all-cause mortality, and then also 97% secondary renal artery patency at 5 years, showing the strength of the graft long term. And then I'll have a slide later on discussing all the trials done in the AAA space. And then this is just another device that I wanted to include. This is from Medtronic. This is the Valiant thoracic stent graft. Now, moving on to AAAs, this is chapter 20. So once again, I'll talk about the pathophys and some epidemiology. So infrarenal abdominal aortic aneurysms, they are usually classified once they're, or diagnosed once they're usually over, they're greater than 3 centimeters in size or over 1.5 times a normal abdominal aortic, 1.5 times greater than a normal abdominal aorta for the patient. But once again, that's different for every patient. If AAA's rupture, there's a 30 to 50% chance of patients dying prior to undergoing treatment, which shows how deadly this condition is and how important it is to get treated rapidly. And also, if a patient has an aneurysm but it's not indicated for it to be treated yet, it's important to have long-term follow-up with that patient to evaluate its progression. There's 15,000 deaths that occur per year from AAAs. Atherosclerosis plays a causative role with these, similar to aneurysms in the thoracic area. And cigarette smoking has a very strong association. So this is a graph from the JVS journal. Um, it showed, it indicated prevalence among AAAs. It compared male smokers and female smokers. So let's just look at one point. So if you're a male smoker and you're approaching the age of 80, then there's around a 10% chance that you have a AAA, which is quite a staggering number. There are 3 different types of classifications for AAAs. Suprarenals, the sac is superior to the renals, and it involves one or more of the visceral arteries, so celiac, SMA, um, and it's runs inferior to the renals as well. Pararenal, there's renal involvement, but there's no visceral artery involvement, so no SMA, celiac. And then juxtarenal, it's just distal to the origin of the renal arteries, so there's no involvement of the renal arteries. And then infrarenal is if there's greater than a 1% centimeter non-aneurysmal segment distal to the renal arteries prior to the aneurysm. So this is the easiest to treat endovascularly because there's a good proximal landing zone. This is really important. I've previously mentioned this. Um, this is pivotal for preventing endoleaks. So I'm going to talk about endoleaks in a later slide, but the infrarenal AAAs is what's able to be treated via EVAR as effectively as possible. The clinical findings are quite similar to thoracic aortic aneurysms and thoracoabdominal aortic aneurysms. So typically they are incidentally found, so patients usually present with no clinical symptoms. If they do present with symptoms, they could have a pulsatile abdominal mass, also nonspecific pain in the abdomen, back, flank pain, and it's difficult to localize. Similar to aneurysms in the thoracic aorta, patients can have limb ischemia. So once again, the aneurysm can act as a nidus. So there is turbulent blood flow. It provides a good environment for thrombus formation. And if the thrombus travels distally, then it can embolize the distal arterioles and arteries. A ruptured AAA, patients can present with severe abdominal pain, hemodynamic instability, and the primary determinant factor for rupture risk is the size of the aneurysm itself. So if a AAA is less than 5 centimeters in size, then there's a less than 5% chance of rupture, but this can increase to over a 50% chance of rupture if the aneurysm is 8 centimeters in size. I want to briefly mention open AAA therapy. These are just some of the different grafts that are used. So polyester graft, you can use a polytetrafluoroethylene graft. Veins can be used. I think the most common vein that's used is the FemPop. And then also a cadaveric allograft can also be used in select patients. VAR gets involved with EVARs. This is a really nice schematic from scientific reports. It labels the abdominal aorta really nicely with a lot of different factors to consider. So this is an infrarenal AAA. There's a good landing zone here. So once again, it's applicable for EVAR treatment. Other important things to consider, the common iliac artery. So this is the landing zone distally. So you need a good evaluation of the iliacs and femorals, both for axis, but also for stent deployment. Moving into the sac itself, there is thrombus formation on the side of the sac. Once again, that's due to turbulent blood flow leading to a good environment for thrombus to form. This is the sac itself, and then this is the covered endograft. This is a image of, I think it's an EVAS treatment. So it's a different type of EVAR, but it differs because the sac itself, this light blue lining, is part of the stents. So you're not relying on the whole endograft to control the blood flow. You have this sac. I wish I put in an image. If I put in an image, it would have made a little bit more sense. But um, you have these endo bags that are able to control the blood flow. And then figure C, this is of the different endoleaks that can occur. I'll briefly mention them because there's another chapter on endoleaks. But you can have a type 1A endoleak. So this is when blood is able to flow proximally. It can happen for many reasons. One of them is if the endograft isn't properly sized, so there's a space between the proximal portion. Same thing can happen with type 1B. So if the graft isn't endosized or if there's severe disease affecting the common iliacs, then it's difficult for the graft to be flush with the iliacs. And as a result, blood can flow back into the sac. It could increase the size of the sac. And then once again, I mentioned how as the sac increases in size, then it increases the chance of rupture. Type 2 endoleaks are when there's retrograde blood flow from different visceral arteries. Type 3 is if there's issues with the graft itself. There's also type 4, which is when blood is able to flow from the pores of from the graft. And then type 5 is due to sac enlargement for unknown reasons. Type 4 and type 5 aren't in this image. And then it's important to know that type 2 is the most common, but once again, there's a different IR playbook chapter on that. Just a very primitive, common way for all endovascular aortic work. This is, once again, I didn't want to include too many details, but you want to get CFA access, maybe even iliac access. You get in using Seldinger technique. You do an aortogram just to get an idea of what the sac looks like and also the health of the surrounding vessels. IVIS can also be used in these cases. You deploy the device, and then once the device is deployed, you do an aortogram, and then you need a closure device. I previously mentioned the large size of the sheath, so I think it's at least 8 French for some of these. So you need a closure device in these cases. And then this is just one example of what these grafts look like. This is a Cordis Incraft AAA stent graft. This is a very comprehensive slide. I included as many trials and registries as I possibly could. I'll talk about them quite superficially. I don't want to go in too much detail. If they're highlighted the same color, that means that they showed very similar results. So EVAR1 showed that EVAR lowers immediate 30-day mortality, but then after 2 year survival, it matches open surgery, and then ruptures are more likely to occur post 2 years. And then lifelong imaging surveillance is mandatory. EVAR2, EVAR on medically fragile patients does not prolong their life. DREAM showed that early endovascular survival advantage vanishes by year 2. So this is similar to EVAR1. And then OVER showed that EVAR reduces early perioperative deaths, but long-term all-cause mortality is identical to open repair. So these are some of the more important pivotal trials in this space. In general, they showed that EVAR was superior to open short term, so around the 2 year mark, but then after 2 years, efficacy and safety was similar in both EVAR and open. ACE, so in patients medically fit for surgery, open is just as safe as EVAR. In the improved trial, EVAR has similar midterm survival to open repair, but gets patients home faster and is more cost effective. So once again, showing that EVAR is advantageous in the short term. You also have IACS and ECAR, so emergency EVAR for ruptured AAAs results in similar 30-day mortality rates compared to open surgery. Window evaluated fenestrated EVARs. I think fenestrated EVARs, a lot of them are usually custom made for the patient, but not always. And then they're usually indicated for complex juxtarenal pararenal aneurysms. I previously talked about these earlier on in one of the slides. The landing zones are quite difficult, making them complex for endovascular repair. But Window showed that FEVAR showed comparable perioperative mortality to open repair, but at significantly higher costs. Once again, I mentioned that some of these have to be custom made. And since they're custom made, I think they take around 4 to 6 weeks to be made. So if a patient requires urgent um, surgery, FEVARs should not be considered if they have to be custom made. And then Pericles evaluated the chimney EVAR technique, and it was highly effective for acute ruptures. So chimney EVAR involves one aortic graft and also individual grafts into the different visceral arteries. And then Anchor showed that mechanically pinning the graft to the aorta with endo anchors successfully stops type 1A endoleaks prophylactically. So if the if there's a good landing zone and anchors are deployed and they're flush with the graft and the artery itself, then it decreases the chance of blood rushing back into the sac itself. These are some graphs showing perioperative mortality among EVAR1, DREAM, and OVER. EVAR was superior to open. And then this is from a JVS article evaluating endovascular repair of ruptured triple A's in comparison to open surgical repair. And findings were very significant. So length of stay was half for EVAR. 30-day mortality was almost half in comparison to open. Major adverse events, once again, almost half. And 1 year survival was higher in EVAR in comparison to open. So apologies for not going too much in depth. I wanted just to get a blanket overview of a lot of these trials and registries. And a lot of them showed that EVAR is superior to open short term, but then longer term results are similar. These are different complications that can arise. So in endoleaks, an endoleak occurs when there's a continued pressurization of the aneurysm sac after device implementation. So I talked about that there's 5 different types of endoleaks. Type 2 endoleaks are the most common. Once again, more details to come in chapter 22. Spinal cord ischemia can also occur. This is not only for EVAR. This can also occur in open repair. A JTCS article showed 5.7% of patients who underwent open repair had spinal cord ischemia, while only 3.9% had that in endovascular repair. This occurs due to coverage or occlusion of the intercostal or lumbar arteries. These images are taken from an earlier IR Playbook chapter. So the lumbar arteries, they arise off of the abdominal aorta, intercostal, off the thoracic. They give off branches that supply the spinal cord. So if the graft is covering them up, then spinal cord can become ischemic if there's a lack of blood flow. And then, of course, the artery of Adam-Kievich, very important artery to know, becomes very relevant when discussing bronchial artery embolization. And then this is a video that I wanted to include. So I want to give a quick shout out to Treat IR Live. This is from the folks at Mount Sinai. They have monthly I think it's monthly procedures that are done live. They always have guest speakers on. It's a great way to learn about complex procedures done in the VIR space. So highly, highly recommend it. This one was a type 1B endoleak. So this was if there's blood flow entering the sac distally. So there's a problem with there's a space between the grafts and the iliac. And then I'll just play a quick clip.
Yeah, you can see the leak there, like it's coming up, but I don't see a leak into the sac itself, which, as I think Jojo was saying, is, yeah, you can stop. It ends up being like a ball valve, right? That it's not open all the time, and it's like this slowly. So his sac didn't have like a rapid expansion; it's slowly growing, and then this is clearly not sealed. If we didn't show you what it looked like before, but when it initially was placed, it was well sealed at this end.
So, as Dr. Patel said, it was well sealed once it was placed, but once again, you have to think about how a patient's lying flat on their back, they're moving still during an EVAR. But once they start moving around, their disease can progress even more. The graft can shift. So it's important to have long-term follow-up with these patients and all VIR patients in general, to evaluate them, see how they're progressing, and making sure that the sac is not expanding. And then I just want to finish off with some final high-yield pearls. So AAAs likely occur due to atherosclerosis and smoking, while thoracic aortic aneurysms occur due to cystic medial necrosis and genetic connective tissue disorder. So I mentioned how the cells comprising these regions are different both in the ascending aorta and descending aorta and distal to that as well. If patients are symptomatic, you always want to treat them. It's important to prep and prep again, understand the patient's anatomy. It dictates the approach. Both the sac itself, access, all of it is important in delivering a graft that is able to be there long term. Success of EVAR, TVAR, all of these endovascular approaches depends on the landing zone. So it's important that once again, you're imaging and you know the patency of these vessels and where the graft can safely land. And then long-term follow-up, this is key. Endoleaks, sac expansion can occur, so it's important to keep track of your patients. And that is it. And if you want to contact me, these are my emails, this is my Twitter. And then these are some QR codes to get involved with our organization. If you have any questions, more than happy to answer them.